Okay, so again, guys, welcome back. This afternoon, we're going to try to put a little bit together. It's actually going to be, it's not going to be too bad, so it's not going to take us too long. But what we're going to do, we're going to put together everything that Colin taught us this morning, and we're going to apply it to actual pathophysiology, so to the pathology of our patients. So respiratory conditions, respiratory diseases, how does everything that you learned today, how is that going to help you as paramedics? How is that going to be relevant? So what we're going to do, we're going to go through three of main conditions that I think would be quite useful to go through together and to really understanding the background of it. And these are going to be asthma to begin with, COPD, and then we're going to conclude with our mentioning of PE. The good thing is, by looking back at all the different presentations, we've covered so much of it already just by doing our inflammatory response, our immune response, the VQ mismatch this morning. So really it should be more like a summary of putting things together. So we're going to start with a familiar one, which is asthma. So what we're going to do, we're going to revise the pathophysiology of asthma. We're going to revise the clinical presentation. What does our patient look like when they've got an asthma attack? And what I would like to spend a little bit more time on as well is the management and treatment of an acute asthma attack. Now, I'm assuming most of you will have seen an asthmatic patient by now. Yeah, lots of nods. I'm assuming good nods instead of sleepy nods. Good, excellent. So most of you will have seen an asthmatic patient of different degrees of exacerbation. So some of them will have had like mild asthma attack and up to near fatal asthma. So you'll have seen different ones. And as technicians, you can manage a fair bit of it, yeah? Excellent. So you should be familiar with the treatment of it as well. And we're going to talk a little bit more of that. So what is asthma? Can anyone give me some sort of a rough definition of asthma? What do you think asthma is? Huh? Okay, a tightening of the airways, yeah? Well, you said that you've seen asthmatic patients. So what is asthma? It's when the patient goes and they need an nebulizer. That's the one, that's asthma. Fair enough, you can't really argue with that. So asthma differs from many other lung disorders, okay? So it's a bit of a particular one. It's going to be in a world of its own because one of the main characteristics of asthma is they have a reversible period of bronchoconstriction. So asthma is a chronic respiratory condition that is characterized by reversible period of bronchoconstriction. And the whole point of it being reversible is when you guys kick in, okay? So it's interesting as a definition because an asthmatic will have this sort of a chronic condition, which means that they will have it most of them like for majority of their life, but at the same time, the exacerbation can be resolved. Unlike other conditions where really it's just gonna get worse and worse as far as the life go on, yeah? Any thoughts of that? Huh? COPD is a great example, absolutely. COPD is also a chronic respiratory condition, but we know that is just going to get worse and worse with time. So patients with asthma may experience symptom-free periods. Now, also this is interesting, as a symptom-free periods, how long can they be? Years, absolutely. It could be, well, I only get an asthma attack every few days, so it could be just a few days of symptom-free periods, could be months, could be years. Some patients tell, oh, you know what, I actually haven't had an asthma attack since I was 7. Now I'm 77, and all of a sudden I got an asthma attack. You know what I mean? And it does happen. Some people will tell you, oh, I outgrew my asthma. You know, but really what they mean is that they've been on a symptom-free period that lasted for several years. Yeah? And these symptom-free periods, they are alternating with acute exacerbations that we are all familiar with. But we're going to talk about the actual presentation of the asthma patient later on. The most frequent form of asthma is the one that develops in childhood, and the age usually between 3 and 5 seem to be the hot spot for start developing this condition. During adolescence, it might get better or it might get worse. I seem to have had a spell of patients going, yeah, no, just at 7 years old, it just stopped. All of a sudden, or at 14 years old, it stopped. And to the point that I actually started looking, does it go in 7 years phases? Is that a thing? Turns out it absolutely does not. It was just happened to have had a spell of patients this way. So it can improve, it can get worse, so on, but it seems to be the most common one is when your childhood asthma that develops between 3 and 5 years old. So let's talk about the prevalence and epidemiology of it. This is fascinating to just talk about it. Aside from the numbers, okay. So the incidence of asthma is dramatically increasing, especially in developed countries, and the existence of asthma, along with different allergies that go with it, is around 15% of children and young people in the UK. 15% of children in the UK that have a diagnosis of asthma or an allergy that might trigger an asthma attack. Now, can we talk about this for a second? Why? Why do you think in recent years the incidence of asthma has gone up so much? Huh? Pollution. Okay, pollution. So we take this as a face value. And so, okay, so the number of cases of asthma in the UK has gone up a lot. Pollution has gone up. So these P10 particles, so like particles that are smaller than 10 micrometers, and I point really they seem to be quite constant irritants of our airway, and they might sort of have caused this increase. Okay, I like it. Anything else? Any other thoughts about the reasoning behind this number?
Obesity.
Huh? Could be, okay. So an increasing weight, so childhood obesity, absolutely. That can make them like difficult to breathe in certain circumstances, absolutely, yeah. Any other thoughts? What was that? Could be environmental, absolutely. Heat, humidity, okay. How about that? Do you think that actually going back is literally the number of cases of asthma has actually increased? So if you ask any of our parents, they'll go, back in my days, no kids had asthma, And now, especially if you look at my dad, he'll tell me now, all the kids have asthma. And what was that? Okay, so here we go. So maybe we start to recognize it. Yeah, maybe over the past 20 years, 15 years, we actually start diagnosing it. We start recognizing it at asthma. That pushes the numbers up, doesn't it? Because if before you didn't know what it was, well, you knew what it was, but if it wasn't diagnosed, then it wouldn't go in the statistics. On the same thought, don't you think there might be overdiagnosed? I'm not saying it is, I'm just maybe overdiagnosed? Yes, I heard some convinced, yes, I think so. And tell me more about it. Why do you think that? Or thoughts about this? Huh?
GPs are quick to diagnose asthma, but it may not be asthma, it could just be an allergic reaction to something.
Okay, so GPs are quick to diagnose asthma. Sometimes, no, absolutely not. I totally get it. We are not generalizing on it. Absolutely. But we are quick to diagnose asthma. Why? Why would you think that would be the case?
Because people want to know. The whole population, even everyone in here, if there's an ailment wrong with you, you want to know you want something or somebody to tell you what is wrong.
Yeah, totally. We kind of want the results now, isn't it? What is it? Well, are you willing to wait until a lot of studies and research? Well, they need to do loads of tests and all the rest. Or you say, well, if I call it asthma, I'm just going to give you an inhaler. And if this happens again, just take this inhaler and it's going to make it better, but then come back and see me. That's what it goes. But at the same time, this has gone down as a diagnosis of asthma in a young child. But let's see it from the other side of it. Would you, as a GP, risk it to say, you know what, let's not mess up with this statistic. Medical statistics are just messed up as they are. I'm not going to diagnose this child with asthma, therefore I'm not going to prescribe him with this medication. Let's just wait and see what happens. Maybe it was just a brief period of anxiety or a small allergic reaction. Maybe he had a bit of a cold that wasn't completely, over it yet. Would you? He said, well, I'll just wait. Let's wait and see if you get another one. It's risky, isn't it? So you can see both sides of it. You can see both sides. You can say, well, fair enough. You don't want to overdiagnose it, but at the same time, if I don't diagnose it and I don't give him the drugs and he does get an asthma attack and the kid dies, that could be a bit of a problem, yeah? So that is that to consider. How about, what is it? It's one of my relatives, and I see, he goes, I see, my cousin, she's got asthma, and my uncle keeps saying it's because when we were your age, we were outside all the time, playing in the dirt. We were never back home, and that's it. We'll come back with like dirty knees, dirty hands, and all the rest. And now you're just keeping everything clean and all, and that's how you got asthma. This is called the hygiene theory. Do you think it's a thing? It might have an element to it, doesn't it? So here we go. So some think that we are keeping our environment a lot cleaner, keep an environment we pay a lot more attention. There is a lot stronger antibacterial substances that we can use around the house and so on. We seem to be a lot more focused on trying to make sure kid comes back home, hands clean and all the rest and stuff. Not my kid in particular, but it's because I'm lazy more than anything else. So that could be it. So it is a much cleaner environment. That actually thoughts are, there's a theory suggesting that that might sort of increase a little bit your sensitivity to then antigens, relatively innocent antigens. Good. Other thoughts about why is the number going up like that?
I think the possibility that people are self-diagnosing with internet and everything like that, so they can go on and they go, yeah, I feel like that. So then when they go to the doctor goes, well, how do you feel? And you think, well, I get this. I kind of think I feel like that. So yeah, well, I get this and I get that. So they go,
Actually, information is up there, isn't it? Absolutely. There is definitely no stigma in it anymore. Maybe more people do present with genuine symptoms, but maybe others do know the symptoms and present without genuine symptoms and say, well, I really want that diagnosis as well. Absolutely. There's a lot more information out there that how is it used or abused, we don't know. Do we survive asthma better? Significantly, absolutely. Say, well, it's not as much as it was before, because before you used to get an asthma attack and died. You know what I mean? So, but now, because of a big advances in pre-hospital medicine and hospital medicine, of course, a lot more people will survive it and potentially pass it on genetically. Yeah? Is that a possibility as well? Definitely. So you see, that's when it comes to when you get medical statistics like this, it's called, yeah, fair enough. We started immediately, a lot more people got asthma, that's it. But let's try to see all of the different points of views of it. Or what could it be? Why is this number increasing that much? Of course, if you ask my uncle, it's because all the kids are now too clean. If you ask someone else, it's because we used to be outdoors a lot more and so on. Well, that's actually another a theory that is being proposed actually just a few years ago. It seems to be that a lot of these antigens that trigger asthma, they all seem to be of origin of indoors environment. So maybe are our kids indoors a lot more than they used to be? So I don't have an answer to any of this. I'm just saying we need to think these things, with an open mind. So around 300 to 400 million people are estimated to have some form of asthma worldwide. So it's quite a lot. So risk factors about asthma. So asthma occurs in families which suggest that is genetically linked. So we know that there is a genetic mutation that makes you more predisposed to have asthma. And about, and I read it just 2 days ago, 3/5 of all asthma cases are thought to be genetically related or to have some sort of genetic element to it. 3 out of 5 is quite a lot. It's quite a lot. And that was a relatively recent paper, I think was 2018, 2019, one of the two. So it's actually not bad. So quite a lot of cases that do have a strong genetic component. Any form of allergies, they do sort of give you some sort of predisposition to potentially get asthma or to trigger an asthma attack. Or, as you all mentioned straight away, any sort of a chronic exposure to sort of airway irritants or atmospheric allergens like smoke, passive smokes from parents that do smoke, or environments where you grow up and such, or pollution, as we all mentioned. When it comes to triggers for asthma, we divide them in 2 groups. These are important words to remember. So it's the extrinsic triggers or intrinsic triggers. Extrinsic trigger is something that comes from the outside. So you've got your, here we go, animal dander, dust, irritants, smoke, etc., household sprays, paint fumes. All these are extrinsic triggers. So they come from the outside to inside the body. And the intrinsic triggers are an infection. So I've got an upper respiratory tract infection, can lead to an asthma attack. Exercise-induced asthma, it's a thing as well. That is an intrinsic trigger. Stress-induced asthma attack as well, I get that. So that is the kind of things, they are intrinsic triggers. Out of all this as well, I didn't add it to it, but another quite relatively common one, especially during the winter, cold air or really hot air, really hot dry air. Some people seem to be triggered there, or others seem to be some very cold air as well. Both of them extrinsic triggers of your asthma attack. So as it was said at the very beginning, your asthma is characterized by this reversible constriction of your airway, right? So there is different elements to it. So because it's a chronic inflammation, really, of your bronchioles, what happens? Well, firstly, so this is like a normal airway. Look at that. It's a beautifully relaxed, smooth muscles all around my bronchiole here, with a nice, lovely, healthy mucus layer on the inside. So we need mucus inside our airway to do what? What was that?
To get rid of...
Absolutely. They're going to trap things in the mucus, and then it's just going to come up with it, yes? So all the ciliate cells inside it will move up the mucus and get rid of things. So we need a certain amount of mucus inside our airway in order to trap all sort of things to avoid them getting into the lungs and causing further damage. Your asthmatic airway, really, we've got 3 elements to it, to an asthma attack. The first one is this mucus layer, this mucosal layer becomes thicker, right? So your mucosal gland, they work a lot more. There becomes more of them, and they actually start producing more mucus. So that's the mucosal gland as one thing. Another thing that produces mucus in our airway is our goblet cells. Your goblet cells also, the sole role of them is to produce mucus in order to help getting rid of all sorts of antigens that I get, or any sort of impurities or irritants that I get inside my airway. So your goblet cells, that's what we get hyperplasia and hypertrophy of both my goblet cells and my mucosal gland. What does these words mean? What's hypertrophy of a cell? Huh? They're getting bigger. Yeah, hypertrophy is bigger. Yeah? What's hyperplasia? Multiplying, absolutely. So there's more of them and they get bigger, you know, and that's how you get this massive production of mucus. And that's one thing, obviously, that is going to help the narrowing of my blood vessel, of my airway. The second thing, because as a result of my inflammatory response, what will I get on my in my airway? There's going to be swelling, isn't it? Because what did we say happens during inflammatory response? Vasodilation. Vasodilation, there is a lot of extravasation of plasma, of fluids, and that causes swelling. Yes? So that is the other thing that will happen to your asthmatic bronchiole, right? That is going to be swelling of it. And naturally, if it swells up, again, the diameter will get smaller due to the inflammatory response. And the third thing, the one that is probably the most dangerous and the one that we try to reverse the fastest, is indeed a tightening of my smooth muscle cells around my bronchioles. So that is bronchoconstriction. Why does the bronchoconstriction happen? You know, why would my body try to suffocate me? Why does he hate me? You know, why does he do that? Why does he want to suffocate me like that? Well, it's a natural reaction of your body to something, to an allergen, a pathogen, an irritant that has gone into my airway, and my body goes, that's it, I don't want any more of that. Thank you very much. So it's a protective mechanism to actually narrow it down to stop the amount of allergens or irritants to actually come into your airway. So that's one reason why we get bronchoconstricted during an asthma attack. But also, something else that happens is a vagal stimulation that does this to you. So it's your vagus stimulation. So when it's a vagus stimulation due to your inflammatory response, that is your parasympathetic nervous system, yeah? On a vagus stimulation, hence causes your bronchoconstriction. So it's a vagal stimulation of your parasympathetic nervous system that causes this bronchial constriction as such, okay? So, and this is the three elements of your asthma attack. You've got an overproduction of mucus, you've got a swelling of the airway itself, and you've got a tightening, a constriction of the smooth muscle cells around the airway itself. And this is what causing my patient not to breathe properly, okay? Now, and that's it, this is another picture of the airway not looking so healthy. That's it, this is like the summary of asthma, that's all it is, right? And you go, okay, this is lovely, thank you very much. This is actually, what we're going to do, we're going to cut this a little bit in pieces, and we're going to go through this together just to sort of make it under. And you see that once we've cut it in small bits, it will make a lot more sense. So, for example, one thing that starts, that certainly begins with predisposes me to getting asthma is, we said, genetic factors. We got some genetic elements to it. But this is the bit that we really want to learn. Atopy, okay? Atopy is a genetic predisposition for your asthma, for rhinitis, and for some certain types of eczema as well. So that is certain. Literally, it's a genetic combination that makes you more predisposed to end up with asthma. And that's what atopy is. And as we said, 3/5 of asthmatics patients are genetically linked. And this is one of the main factors. So here we go. So I even put a definition in there for you. So atopy refers to the genetic tendency to develop allergic diseases such as allergic rhinitis, asthma, and atopic dermatitis or eczema. The result of this genetic combination is that you end up with a heightened immune response to common allergens, something that otherwise shouldn't almost kill you. So things like pollen, things like certain smoke and things like that. But so you end up with a heightened response to these otherwise common and otherwise it should be not so bad allergens. So let's talk about the first exposure to your triggers. So how does this happen? Okay, so okay, fine. You said I was born and I've got this genetic predisposition to overreact to certain allergens. But how does that start? How does everything begin? Well, initially, you will need to have an initial exposure to the allergen. Yeah? So the first time that you get exposed to it, you don't have the same reaction. So what would happen the first time? So let's take an allergen example. Let's say, I don't know, pollen. Pollen, shall we go for pollen? Pollen, we'll go for pollen, right. So let's say a young kid gets exposed for the first time to pollen. Pollen comes into the airway because, I don't know, it's around smelling a flower at 3 years old. That's nice, okay? And the pollen starts coming in. What happens to the immune response of this young child? You start getting things like macrophages, dendritic cells, and that's what Colin, you remember he was saying, those are antigen-presenting cells. So if I had a dendritic cell, would you present me with an antigen? So here we go, look at a wonderful macrophages here that has taken. So thank you, here's my macrophage coming in. Here we go. That is picked up an antigen right there. Here we go, and it goes, who is it going to present it to? Here we go. Thank you. To a helper T cell. Okay? So the T helpers, thank you, macrophage. Here we go. T cell, I'm a T cell. Yeah? So I'm a T helper cell. You know? I'm a T helper cell that at this point I get presented with this antigen. Right? And I go, okay, so I've got an antigen here. That's pretty bad. I should probably tell someone about this, yeah? I should probably tell someone because a T helper cell can't just hold on to this and not telling anyone, okay? So they'll need to start releasing some information and start releasing some cytokines to say, hold on a minute, I need to tell someone. And these cytokines, this information is gonna be sent to B cells, yeah? My B cells will receive this. So this one, my T cell is going, well, I can't go anywhere because I'm a helper T cell. In order to tell, I'm just going to start sending our cytokines out all over the place, right? You go. Tell everybody about this antigen. We do not like pollen. This is the message. I repeat, we do not like pollen. Please let all the B cells know. And that's what happens. So all my cytokines goes out. And we talked about it last week, didn't we? My cytokines are just messenger proteins. Yeah? And what they do, they reach my B cells. That Colin talked about it a lot. So my B cells, they receive the message. And they go, wow. This pollen guy, we do not like it, okay? So we need to do something about this, right? So what they're gonna do, the B cells, they're gonna start producing immunoglobulin, yeah? So antibodies. They're gonna produce antibodies with on top a piece of that, and they go with almost like a wanted dead or alive picture on it, you know what I mean? So this we do not like. If you find this inside a body, we do not like it to be searched and destroyed. Okay? So that's what your antibodies will go. Brilliant. So now we produced antibodies that they will respond to the presence of that same antigen. Now pollen, we don't like. And these specific antibodies, that's what they're for. But they can't just float about going, I'm an antibody and I don't like pollen. They can't do that. No? They need to connect to something else that will actually have a good response to it. What is it? Huh? Wait, you're skipping the most important step here, right? Who releases histamines? I heard it, please say it out loud, whoever that was. Mast cells. Absolutely. So this immunoglobulin or these antibodies, same thing, what they do, they will start getting on top of the mast cells and they go, Mast cell, don't you worry. If I see any of that, I'll let you know, okay? And that's how the mast cell knows how to work. So what was so exciting about mast cells? Everything, of course, I know. But what was the main feature about mast cells that we covered last time? They degranulate, so they've got preformed granules inside them, yeah? I love to think about mast cells as a loaded shotgun, you know? Because you think about all the, so it's not a bullet that it's got, isn't it? So it's like you've got like loads of granules inside, ready to fire if something was to happen, okay? So now, this complex immunoglobulin mast cell complex, right, is what we call a sensitization of my airways. Now, my airways are now lined with this IgE mast cell complex, loads of loaded shotguns ready to go. You know, because, and this is great, if this was to show up again, right, what you do, you got all these mast cells starting to literally degranulate, right? And think about like when a shotgun fires, you got all these pellets just flying all over the place. That's exactly what would happen. But instead of being lead pellets, it's what? It's heparin is one. Histamine is another one. Leukotrienes, all sorts of things. Yeah, absolutely. They're going to just come out of your mast cells, triggering a massive inflammatory response. And that's how the initial sensitization of your airway starts. That's it. Really. That's what it means. Sensitizers help it. That's what it means. That's what it means, you know. And I've got, I love the image. I've got like an airway lined up with like loaded shotguns, good to go in case like that pollen or smoke or whatever else was to get inside my airway. At that point, they'll start degranulating massively. So this is like chapter 1. In the next chapter, antigen shows up. Okay? Right? And that's it. So, second exposure to trigger. That's it. So it shows up again. Well, we, as far as pre-hospitalists, as far as pre-hospital care providers, this is really, let's face it, where we're gonna go most of the time. So don't get me wrong, we do have patients going, eventually that had like an asthma attack lasting for 3 days, and then eventually they call an ambulance. They go, oh, I can't breathe very well now. She's been going on since Friday, you know, that's Monday morning, you know, classic crash call Mondays, you know what I mean? Classic. But most of the times we would end up within the first couple of hours of the triggers having, or the asthma attack having started. So the allergens, the cross-link the immunoglobulin on top of the mast cells. Colin explained it very well. How did that work? So the pollen in this case just shows up again. The immunoglobulin finds out, whoop, and what they do, they activate my mast cell, and the mast cell will start to granulate and will start producing histamine, leukotrienes, heparin, and all sorts of inflammatory mediators that we talked about. And this will cause vasodilation, causing the edema of my airway. My goblet cells, hyperplasia. We talked about it a minute ago. Increased mucus secretion, and then bronchial smooth muscle contraction as a sort of as a protective mechanism of your respiratory system after the exposure to a trigger that you don't like. You go, I don't like anymore, in. And secondly, as a vagal stimulation, right? So that is really a stimulation of your parasympathetic nervous system in this case, from your vagus nerve, that will cause this bronchial constriction, okay? And this is where you get your airway obstruction, and that's an asthma attack, essentially, okay? Over the longer period of time, there is a delayed response after it as well. And here we go back down the route of everything that Colin explained last week, of your eosinophils and your wider immune response that will sort of try to clear the antigen and stuff. But this is literally it. My overreaction to an otherwise innocuous trigger, and that was due because of my genetic predisposition to it or any other reasons that we discussed earlier on. And that's what causes my main asthma attack. Does that make sense? Yeah? Good. So the initial exposure is not going to do anything other than, all of that. And then my second exposure, that will get my asthma attack, and so on and so forth. Good. Now, I know it's ridiculous. It looks just very asthmatic. He was just coughing. I don't know. Anywho. Huh? I know, that's why I didn't want to laugh the first time I presented, but it's cool, man. So, clinical presentations of an asthma attack, especially the somnolence one in the room that are struggling to keep their eyes open, which is fair enough. I get it. It's asthma. We know it. Come on, give me some clinical presentations. Wheezing. Okay, more. Well, we didn't understand a word of that. Say it again. Cough. Okay. What else? What was that? Red to begin with, and then, if you're there quick enough. Yeah, absolutely. Potentially what it might lead up to as well. Some cyanosis afterwards as well. Absolutely. So we've got lots of. So they're going to be breathing quite fast, aren't they? Yeah? So at least they're going to be trying to breathe quite fast. Bless them. You know what I mean? So absolutely. Tachypnea, wheeze, breathlessness, cough. So that's just some of the clinical presentations. These things might cause hypoxia, cyanosis. They might get quite fatigued, and eventually we might lead to hypoxemic respiratory failure in these circumstances. How do we diagnose the asthma attack? Any thoughts? Huh? Oh God, and well, if it's silent, you took your sweet time to get there, didn't you? You had to stop for coffee. No, I'm not rushing for no one. So, but no, absolutely. Jokes aside, it might get to that point, depending. It could be the patient that is very far away. Any other diagnosis tools? And how do we diagnose an asthma attack? What was that? Get a history, if you can, from the patient or someone near the patient, someone that comes at the door quickly and goes, oh my God, my son, my brother, my husband, whatever it is, it's got asthma, Okay, now I know it's potentially an exacerbation of that and it's not something else. I know what you're thinking. Goes, well, Dan, if the patient goes, it's probably asthmatic. Fair enough. So we talked about the wheeze. Anything else? On auscultation. It could be silent. Otherwise, what do we call it when we auscultate with a stethoscope? I heard it. An expiratory wheeze, absolutely. So a wheeze on expiration. Why is the wheeze mostly on expiration? Because by positive pressure, as Colin says this morning, eventually air will come in. Unless it's really, really narrow, then you can get really, some wheeze both in and out, But in this case, it's when the air tries to get back out that they're trying to force it back out. It's almost like a whistle, isn't it? That you blow in the whistle and the narrowing in it that causes the doing that. Yeah? So it's an expiratory wheeze. Yeah? The patient, well, exactly, an acute exacerbation, as I said, are usually quite easy. Otherwise, what else we've got? The chest is hyperexpanded. Accessory muscles will be in use. The sternocleidomastoid, that goes from here, works all the way up. See, I was going to go the other way around, but let's not make this mistake. Sternocleidomastoid. Here we go. So up this way. This muscle in particular, trying to sort of expand your chest as much as possible in trying to get more air in as much as possible. The scalene and the obviously intercostal muscles are used. As the bronchoconstriction worsens, we can get the wheezing that might disappear, and here we go. Then we must start getting a silent chest. So, when we get to the silent chest, it doesn't mean that the asthma has resolved. Yeah? When we get to that point, means that it is not very good where we're at this point, okay? But auscultation is really, really important in this situation. I want to know what level of wheezing, so how bad is that wheeze? That it might be some patient with chronic condition which are constantly wheezy, yeah? But how wheezy am I at this point? So when you're going to start giving them treatment, you're going to start giving them your salbutamol, your ipratropium, potentially adrenaline, depending how bad it is. Is it improving, yes or no? Well, that's what a point when you start going, well, it's still wheezy, but is it better? Is it not? Are they making the same respiratory effort and the wheezing is get better? Or they're getting very, very tired and it's starting to get silent, that chest? You can see how really by the same kind of, the clinical feature, if you were to write it down, is very similar, but one means that they're about to die, and the other means that it's actually your treatment is helping. So a good auscultation, despite someone saying, yeah, of course it's asthma, just give them the treatment, listen. That's the only way you're going to have to know if your treatment is actually doing something or not, okay? Won't take long. If it's two of you, one prepares the drugs, the other one just takes a pair of tubes out and has a quick listen to the chest, or better, to the back of the patient. Okay? Make sense? Good. So let's talk about the treatment of asthma. This is teaching you how to suck eggs. This is very much at technician level as such. Sit the patient upright, lying them down is not going to help in this situation. If hypoxemic or cyanose, give high flow O2 as soon as you can, absolutely. Once nebulizer available, give some salbutamol as per GR Calc, and then nebulized ipratropium. Come on, you know exactly where I'm going with this.
Yes, with combination.
Huh? I'm sitting down now for this, yeah, okay. Yes, you combinate. Why? Huh? Okay, I like an honest answer. Any other answers? Huh? Time critical. So does a combineb work better or faster? Does it? If you have any evidence of that, I'll be incredibly interested to see it.
Not in asthma, but in COPD where you're limiting your nebulization to 6 minutes.
Ooh. Okay.
Because you can deliver them both and then allow that rest period in between.
Oh, hold on a second. Here you made a statement and a half. You can deliver them both through the one neb, mixing them the two together. Do you have evidence of that? I would love to see that. I would love to see that. So let me tell you, what was that?
You're supposed to progress to see what drug is actually having an effect on your patient.
Thank you. Absolutely. So I of course, I mean, I'm not coming preaching, or of course I combined patients for ages. Why? Because when I was a student technician, I met a student from GCU, straight on the road, I think probably day 2, I get someone with some near fatal asthma, and I was going, what do I do? I was getting a panic attack, the patient was about to die, and I was told all sorts of things to get the chair, get the blanket, get the neb, get the salbutamol, get the ipratropium. I didn't know even how to open that bag. With massive brain fart in my head on how to get the ramp down. It was the old Peugeot, and I was like, it was harder. You know? So, and of course, the paramedic I was working with said, put both of them together. Okay. Why? Because we need to hurry up. No problems. Who am I to question this person? You know? Who am I to question him? Of course I've done it. And do you think I looked into it afterwards? Absolutely not. The next patient that I seen for myself that's struggling with asthma, you know what I did? The first thing I did, I'll put them both together because I know it works. You know, because I've been told, and that's how it works a lot faster. Unfortunately, ladies and gentlemen, when you start looking into it, this whole procedure, that I don't blame anyone for doing it, because as I said, I've done it myself many times, until you start looking into the whole, but does it work? Really? And unfortunately, first of all, the science towards it is quite clear about it. It goes, well, they have a different viscosity, these two drugs. They suspend on one another. So you don't deliver them both at the same time. You really don't. Second, in order to start mixing drugs, we really should be pharmacists before doing that. So it's completely an off-license thing to do. And we called and we said, dude, no, before we say things like that, we need to research this. And we did. We spent an unholy amount of time. So who suggests that we shouldn't mix drugs? Answer is everybody, from the College of Paramedics all the way to, well, as high as you can get on the pharmacological, what was it? The government, all the way to the administration of drugs, all the way to the government. No, unless you're a pharmacist, you should really not mix up drugs because you don't know what you're doing. Fair enough. So what is it that we call it? A combivent. Is that what we call it? A combivent is a completely different drug. So it's not a completely different, but it's a completely different presentation. It's a nebule that is being changed in order to the two drugs to actually work together, different dosage for it. But it is, you take that one nebule, you crack it open, and in about 2.5 mils, I think, you have both drugs, like that. That's what a combivent is. It's a different drug, or it's not, again, I say a different drug, it's a different presentation altogether that indeed has both drugs in it, but they are designed, they are engineered so they would actually work together. And this indeed, a COPD patient, would they have though? Possibly, of course, they will have them. You say, shall I give them both to my COPD patient if they've been prescribed it, by a pharmacist? Different presentation, absolutely. We might see it around, and definitely the two drugs together, they work marvelously well together if they are indeed designed to work together. The way we have on our presentation, we end up with something about 7 mils of fluids inside our nebulizer with two drugs that suspend on top of each other, and they're not supposed to work together because they just don't. They don't mix inside your nebulizer. That's the problem. So really, we end up to hospital with this amount of fluids inside a nebulizer. We get to resus and go, what did you give them? X amount of salbutamol and X amount of ipratropium. Have you though? You have no idea how much salbutamol or how much ipratropium has gone into that patient. Really. And that's it. Now, am I saying, you guys in your practice, you're going to be independent practitioners, you do whatever you want in your practice. But what I'm saying, no, genuinely, it's really none of my business what you do on the road. We are here just to sort of saying, let's debunk a few things, okay? Because I got caught out by being told, Dan, that's better, it's quicker. It's not quicker, we are not allowed to do it, technically, and it actually doesn't give my patient any benefits as such. But anytime, well, should I argue with every paramedic that I work about? No, don't. If you don't want to, don't. It's your practice. But what I want you to do is to become thinking paramedics and thinking technicians other than let's do things because someone told me to. Does that make sense? Is that fair? Yeah, then obviously on the road, if you say, well, I'm going to carry on doing it as long as a lead clinician tells me to, I'll do it. Whatever. But I want you to start think, okay, but doing with the knowledge of what's happening in that nebulizer, okay? Alternatives, yeah, you have two different nebulizers and you administer one first and then the other, okay? Now, if we're going to be told, well, we'll put combivents anyway. Okay, so someone tell me what salbutamol does to your patient. If we are so happy, huh? Oh, I like it. Does it reduce bronchospasm? How? That's what I want to know. How does that work? Beta receptors. Which ones? Colin talked about two different ones last time. Beta 2. How do I know that it's beta 2? Because I've got two lungs and one heart. Beta 2. Look at him, so happy. There you go. Absolutely. Beta 2 receptors, I've got two lungs. Beta 2 are most commonly in the lungs, and beta 1 receptors are most commonly in the heart as such, and the alpha adrenergic receptors are in your blood vessels. Good. So the first thing is, salbutamol, the way it works, is an adrenergic, a specific beta 2 adrenergic agonist. Yeah? So what does that work? What does it act like? If it's an adrenergic agonist, is it going to have the same effect as what? If it's an adrenergic receptor. Adrenaline, absolutely. So it's very specific and acting on beta-2 adrenergic receptors, and it's going to make it act as if it was adrenaline, yeah? And what does adrenaline do? Well, we know that is a vasoconstrictor and a bronchodilator, absolutely, is going to indeed relax the smooth muscles around my bronchioles, okay? Brilliant. So we said, but we've got ipratropium as well, but using ipratropium as well is great. Now, it sounds like I'm at war against ipratropium. I love ipratropium bromide, you know? But what is it? Why the two of them work? Well, if you actually administer both, what does ipratropium do? What was that? Is it anti-muscarinic. What does that mean, though? Huh? Yes, to a point. So what's your muscarinic exit? So it's an anti-muscarinic, you know, so it's an antagonist, you know, so it's going to avoid, you know, acetylcholine to just like bind to your receptors. Why? What did we say causes that bronchoconstriction? What type of a nervous system is?
Stops your smooth muscle contraction.
Absolutely. So it's a different path. It does the same thing, but from a different path. Instead, it stops the stimulation of your parasympathetic nervous system, really, which your acetylcholine is one of the main neurotransmitters of it, okay? And it's going to go, well, yes, that's what I do now, yeah? I need to go and constrict those bronchioles. And what ipratropium bromide does, it sits on that receptor instead. It goes, no, enough of that. Enough of that nonsense. Let adrenaline do its thing, or let salbutamol do its thing, okay? So that's why the two things, they act from two different angles, but they do essentially the same thing, but from two different aspects. That's why it's important that the patient actually gets in both, right? So here we go. Okay, well, we talked about that. So here we go. So that's your salbutamol. This is your beta-2 receptor up here. What it does through adenyl cyclase, so this is a G protein activated receptor. So what it does, it turns adenine triphosphate, so your ATP, into cyclic adenine monophosphate. And what it does, there's an inhibition of calcium release, right? And that causes smooth muscle relaxation, okay? This links in nicely to both last week and next week. So here we go. So the onset, so that's the other thing. Salbutamol onset about 5 minutes, and the duration in my system about 4 to 6 hours. Now, my ipratropium bromide, acetylcholine, which is my chief, go back, that's one. Is my chief neurotransmitter of your parasympathetic nervous system, and is an antagonist of it via blockade of the muscarinic cholinergic receptors. Onset takes about 20 minutes to work, your ipratropium bromide, but fair enough, duration is about 3 to 6 hours as such, okay? So at least now we know how we both work, okay? Now, let's talk about further treatment, near-fatal asthma. We get to near-fatal asthma when we get what? Hypoxemia below 92% on the SATS probe. A silent chest. The patient is really badly cynosed. The level of consciousness is that my GCS is starting to get reduced. The person is starting to get quite tired. It means that they've given up sort of trying to, so there's a big active process, because let's not forget, I'm starting trying to breathe in as much air as possible. I also need to put a lot of effort trying to blow all that air out. So the patient will get tired. That's when we're going to get at that point. If the bronchoconstriction is not reversed at that point, that's where you might end up with a dead patient. Because imagine the actual ventilation while they're unconscious or obtunded is very difficult. How easy do you think it is to intubate an asthmatic patient with a near-fatal asthma? Very, very, very difficult. It's just you need to very much call the big boys to do that. The ones that go, oh yeah, fair enough, it's a terrible airway. Good. You deal with that. Right? Good stuff. So at this point, so what we're going to do as other further treatments, what we've got, adrenaline. Adrenaline 1 in 1,000. 1 in 1,000, not to confuse with my cardiac arrest adrenaline, of course. My 1 in 1,000 adrenaline, what does it do? Well, as we said, as a vasodilator and a bronchoconstrictor, yeah? So what it does is what does it do? It will start reducing the swelling by the act of vasoconstriction, which is going to be on your alpha adrenergic receptors on your blood vessels, I suppose. And on both your adrenergic receptors, beta 1 and beta 2, so that's why you get a little bit tachycardic when it comes to injecting adrenaline, yeah? That's why we prefer salbutamol, because it doesn't have that particular side effect, yeah? It acts specifically on your lungs. But when you give adrenaline, it's not as selective. It will act on all the adrenergic receptors. It's got a big systemic reaction on all my blood vessels, all the adrenergic receptors, okay? So that's my adrenaline 1 in 1,000. But what it does, it acts really quickly and is a good vasoconstrictor and bronchodilator. And then last, I was going to say but not least, but yeah, I would go with last and least. It's hydrocortisone here. I mean, the onset, it takes about 2 to 24 hours to actually start being of any use, your hydrocortisone, okay? If you're en route with a neonatal asthma or a nasty asthma attack or whatever, I would not waste much of a time trying to reconstitute your hydrocortisone and it's a nightmare because they start frothing and all the rest. So you're going to start swearing at the little ampoule and all the rest. Not worth it, really, if it's a time-critical situation. Because your hydrocortisone, what it does, it's great. So it very much works as a genetic level, okay? So it reduces the expression of cytokines and prostaglandins in your inflammatory response. Another thing that it does, you remember we talked about the neutrophils just extravasating, yeah, from your blood vessels going into the area of inflammation. It stops them doing that, or it sort of reduces the messaging for them to do that. So it's very useful what it does. That's how it dampens down your inflammatory response, but it does take a while to actually start working. Okay, so hydrocortisone, yes, but really start thinking of where is your time best spent. Now, are you all familiar with this? Please say yes. Yes? Yes? Okay, good. So you're all familiar with this. Okay, how does it work?
The algorithm that we use for asthma.
Yeah. So that's the algorithm that we use for asthma. Good. So how does that? How do I use it? Huh? Top to bottom.
Well, it depends if you go into your patient and you see that they've got a silent chest wall, you're just going to jump right to life-threatening asthma.
Okay, so it's not a checklist of things that I need to do. I'm looking for no. No, it's not. Okay, so it's a stepwise approach. If you've got quite a mild, moderate asthma, you say, well, I'll start here. Let's move them to a calm, quiet environment. Let them administer their own nebulizer, etc., and start to move on. But if I start getting a life-threatening asthma, do I tell the person, start getting a nice, quiet environment with me, and let's see if this is going to resolve it? Would that be a good use of your time? Or shall we start giving them some adrenaline? Yeah, so let's do that, like straight away. Yeah, let's start giving them some adrenaline at that point. So you go, okay, I understand. In that case, we get here and we work from the bottom up. Yeah? But then suddenly, I'm getting to my steroids here before my ipratropium and salbutamol. Yes? No? No, especially if I started with life-threatening asthma, let's not start wasting time on my steroids before I've actually given something that can resolve that bronchodilation and sort of that bronchospasm that I want to relieve. Okay? So this is a terrible tool that we have for asthma. I understand it's not very clear on how it is used. I've seen loads of people just starting from the top regardless. It's okay, I'll start with this and then this and use it as a checklist. It's not a checklist, okay? This is not, yes, I can start, I start from one bit fair enough. But if I've got severe asthma and start working my way down, do I skip salbutamol altogether? No, I don't. Do I skip oxygen? No, absolutely. Around here as well. I mean, let's put that oxygen on as soon as we can. So as you can see, it doesn't really have an exact order. That's what I'm asking you. Yes, this is the tool that we're going to use, but also I'm going to ask, be thinking paramedics in the future or be thinking technicians as you are now, okay? Is a tool? Yes. Is a good way to remember things? Yes. It's not a checklist. It's not a list in which you can do a certain order, okay? That is your clinical judgment. That's what you need to use. Okay? This is to remind you what you've got in your arsenal as tools to resolve asthma. Yeah? Any questions? Yes?